Now, how do you apply this in your practice? Well, we would suggest that all patients that you see in your practice, you ask about whether they're a cigarette smoker. Now, when I say that, I mean not just a current cigarette smoker, but whether they've smoked cigarettes in the past. Because even if they stopped, they fit into our group of patients who have COPDGene 2019 and have risk of all-cause mortality and risk of progression of the abnormal spirometry. So we ask all patients about former history of cigarette smoking, not just current history of cigarette smoking. And then in all patients who have cigarette smoking history, ask them about symptoms. Well, how do you do that? Well, ask them about cough and phlegm. Now, one of the things I teach medical students all the time is I say to the medical students, well, tell me how you would ask about cough and phlegm. So the medical student says, well, Mr. X, do you have cough and phlegm? Well, that's not necessarily the best way to ask, because if you're a long-term cigarette smoker, you've had cough and phlegm for so long you think it's normal. So it may not be the best way to ask the question. The way I like to ask the question is, the first thing in the morning when you get up, do you have some cough or do you bring up some phlegm? And patients will say, yeah, well, that's a smoker's cough. Everybody I know who smokes has cough and phlegm that way. But that's chronic bronchitis. That's not normal. So that's one of the symptoms that puts patients in the classification of abnormal symptoms. What's the other thing you ask about? We ask about shortness of breath. You know, shortness of breath is based upon what you do. And if you're a couch potato and you're sitting at home watching TV and you're retired, you're not going to walk enough to know whether you're short of breath. So you need to ask patients about what they can do, how much they can do when they walk. You might ask, well, you walk up a slight hill, are you short of breath? That's shortness of breath. Or when you're walking with your spouse or your buddies, do you get more short of breath and have to stop before they do? Or when you're walking your own pace on level ground, you have to stop. That's some ways to ask in a standardized manner whether patients have shortness of breath. So if they have symptoms, they fill the second part of the triangle, okay? Cigarette smoking plus symptoms. Then you might think about, well, when do you do spirometry? Well, you know, doing spirometry in everybody who comes in, you know, isn't necessarily very cost effective as national societies in the United States have suggested, and Preventive Services Task Force has suggested. But this is not doing spirometry on everybody. This is targeting spirometry to people who have symptoms. So I would certainly think about patients who have a cigarette smoking history and symptoms. Spirometry should be done on almost all those patients. If you can't do spirometry, send them to somewhere that does. Maybe there's a physician in the next office building who's an allergist or a pulmonologist, and maybe they'll do spirometry for you. Maybe you don't have to send them to the hospital. Maybe you can send them to a physician's office that does do spirometry on a regular basis. And then also think about CT imaging, because if you're going to put patients into our diagnostic paradigm of COPDGene 2019, CT imaging is the next abnormality you need to think about. Only when you identify these four features can you identify patients who are at increased risk of mortality and increased risk of progression of their physiologic abnormalities on their spirometry. And then figure out how you might treat that patient. Well, one of the most obvious things is if they're still smoking cigarettes, you might really focus on that very intensively over a long period of time to stop them from cigarette smoking. Now, we know that cigarette smoking is a chronic relapsing disease, and people start and stop all the time, so you need to consider that over the long term when you're following the patient. And every visit, ask them whether they're still smoking. Smoking cessation is associated with a decrease in mortality and a decrease in risk of progression of spirometric abnormalities, as well as a decreased risk of lung cancer and other cancers, many reasons to stop cigarette smoking. But if patients are in the COPDGene 2019 probable or definite COPD category, then it's really important. So this next graphic is another way to think about it, okay? Patient walks in with exposure cigarette smoking history on the top in the black. Then where do you go? You go around the circle to the right and you ask them about symptoms. If they have symptoms, this puts them in a classification category already that they may have COPDGene 2019. And if they do, definitely, I would think, go into spirometry and CT scan imaging. CT scan imaging is important not just for finding the structural abnormalities that are associated with cigarette smoking, but also for lung cancer screening. So think about CT scans very importantly in this population. Thank you very much.